Good day. Today we will be looking at the patient case report about cystic fibrosis. The respiratory and digestive systems are the main organs affected by the hereditary disease known as cystic fibrosis. A faulty protein is produced as a result of the mutations in the CFTR, or better known as the cystic fibrosis transmembrane conductance regulator gene. This protein is essential for controlling the flow of water and salt in and out of the cells. Consequently, thick, sticky mucus accumulates in the lungs, pancreas, among other organs, in people with cystic fibrosis. This mucus can cause serious respiratory problems, block airways, and encourage bacterial infections.
A 3-year-old Caucasian female came in and presented with the following: a persistent cough, shortness of breath, and increased sputum production. She lives in a medium-class family with one older brother. Both parents and siblings are healthy. She has been admitted to hospital 2 times in the recent past with respiratory exacerbation and had multiple respiratory infections. As a baby, she had failure to thrive and resulted in her being very small and thin for her age.
The mother explained that the patient presented with wheezing and was a very fussy baby. She was prone to sinus and ear infections. During her previous hospital admissions, she was treated with IV antibiotics. This eased her symptoms, but it did not really get rid of her problem. A dietitian in charge of the patient also said that she was not properly absorbing her food, and she was put on a high-calorie diet.
The patient presented with a chronic cough and a noticeable increase in sputum production over the last few months. She has persistent shortness of breath accompanied by a rapid and shallow breath. She is very thin and appears physically weak. She has a mild wheezing of the chest, and she has frequent greasy stools with abdominal discomfort and bloating.
Looking at the case, we used 3 types of diagnostic investigations. Firstly, a full blood panel was performed for the patient, including a white cell count, hematocrit, HP levels, liver and kidney function tests. Patient was also genetically tested for the CFTR mutation of the gene. Patient also tested positive for this abnormality. Secondly, we did a sweat chloride test. Patient tested positive with a result greater than 60 millimoles per liter. Patient had a spirometry test performed where the results showed that she had 60% of the normal capacity of her FEV1 levels. Sputum cultures were also being sent for testing and came positive for Pseudomonas aeruginosa.
Cystic fibrosis and a few other respiratory diseases, such as asthma and bronchiectasis, are all conditions where the patient presented with a chronic productive cough, wheezing of the chest, and can be associated with both sinus and ear infections. Cystic fibrosis can be distinguished by the gene abnormality in the gene CFTR, and this is the main test we perform to make the diagnosis for cystic fibrosis.
When taking into account the patient presentation as well as all the diagnostic tests performed, we looked at 4 steps. Firstly, the baby was screened as the newborn, and we had a clinical presentation that raised suspicion of her having abnormalities. Secondly, the sweat chloride test was performed. Patient tested positive, and CF was confirmed with the patient. If we were unsure with our results, we could have taken up genetic testing, which in this case we did. Patient was tested for the CFTR gene. And then if any ambiguity remains, advanced tests like NPD or ICM were performed. By combining the multiple tests and clinical insights, diagnostic integration improves accuracy, particularly in cases with atypical CF presentations or uncommon mutations. This approach is crucial for early detection, ensuring appropriate treatment can be promptly. We can also request a chest X-ray for the patient to determine whether the lung structures and if she might present with any secondary complications like hyperinflation.
When treating CF, we can either treat a patient through non-pharmacological or pharmacological manners. Non-pharmacological manners is like physiotherapy that helps to clear the airway and loosen mucus. It also reduces the risk of lung infections. By employing exercise, we can help to mobilize sputum for easier clearance and improve endurance of respiratory muscles. The last resort is a lung transplant, treatment which is the treatment of choice when lung function declines critically. The timing of the transplant is really crucial.
When looking at the pharmacological treatment for CF, we can look at three types of medications. Firstly, we can have mucoactive agents. We can provide the patient with hypertonic saline and mannitol powder, which helps thin mucus for easier clearance. Patient can also get Dornase alpha or pulmozyme. It's an enzyme that hydrolyzes DNA in mucus, reducing its thickness. Secondly, bronchodilators. Bronchodilators helps manage our bronchospasms. This widens the airway to improve clearance of mucus. Lastly, we can give the patient antibiotics. We have 4 different classes. Firstly, penicillin, like amoxicillin. We've got carbapenems, like meropenem, tetracyclines, doxycycline, and lastly, vancomycin.
CF is an inherited disease that is caused by a mutation in the CFTR gene on the 7th chromosome. The CFTR gene provides instructions for the production of the CFTR protein, which regulates the movement of salt and water in and out of cells. To develop CF, an individual must inherit 2 mutated CFTR genes, one from each parent. More than 2,000 mutations in the CFTR gene can cause CF. The most common mutation is a missing part of the CFTR gene that leads to a misfolded protein that cannot function properly. Some mutations result in little to no CFTR protein production. Consequences of a faulty CFTR protein is thick and sticky mucus due to reduced water content, blocked airways that leads to difficulty in breathing and lung infections. Nutrient absorption is affected by a clogged digestive system, and increased risk of dehydration due to excess salt in sweat.
When looking at the epidemiology of cystic fibrosis, it's most common in Northern Europe, occurring in 1 out of 3,500 people. There's a low prevalence among the Black population, only 1 in 15,000, and our Asian population, 1 in 30,000. In 1996, only 6% of CF patients were adults, while in 2014, over 50% of CF patients were adults. The median predicted survival age was 39.3 years between 2010 and 2014. The projected survival for those born in 2010 was 56 years. Risk factors related to early mortality included health factors like malnutrition, chronic respiratory infections, and pulmonary exacerbations. The highest mortality rate is seen in females.
The pathogenesis of CF. CFTR protein transports chloride and bicarbonate across the apical surface of epithelial cells, found in the lungs, sweat glands, gastrointestinal tract, pancreas, and reproductive system. The lungs and airway surface. CFTR regulates the airway surface liquid hydration by balancing chloride secretion and sodium absorption. That is important for cellular function and antimicrobial defenses. A decrease in chloride secretion and increase in sodium absorption led to dehydration of the airway surface, leading to thick and sticky mucus. The gastrointestinal and pancreatic effects. Thickened secretions will clog the pancreatic ducts, preventing enzyme release. A decrease in bicarbonate secretions causes acidic chyme in the duodenum that deactivates pancreatic enzymes. The result is malabsorption, leading to deficiencies of fat-soluble vitamins like vitamin A, vitamin D, vitamin E, and vitamin K. Sweat glands and fluid balance. CFTR reabsorbs chloride in sweat. In CF, chloride cannot be reabsorbed, causing excess sodium and chloride loss. This will lead to salty skin and, in severe cases, hyponatremic dehydration.
So how does this disease progress? Firstly, we have early presentation found in newborns and infants. Newborn screening is vital. Many diagnosed before any symptoms can actually appear. Common symptoms include gastrointestinal issues like meconium ileus or prolonged jaundice, failure to thrive, poor weight gain despite adequate feeding, and early lung infections with recurrent sinopulmonary infections. In males, we can see undescended testicles. The median age of diagnosis is between the ages of 6 and 8 months, but it can vary. Following childhood and as adolescence, in your respiratory tract, you have frequent lung infections, a chronic cough, and bronchiectasis. The digestive tract shows pancreatic insufficiency, malabsorption, anemia. Intestinal, we've got distal intestinal obstructive syndrome, and musculoskeletal, we observe osteopenia or osteoporosis, followed by scoliosis. Adults with CF affects multiple organs, leading to worsening symptoms.
During recovery, CFTR modulator therapy is used to slow disease progression. Aggressive pulmonary and nutritional care improves lifespan. Life expectancy has increased to 50 years in developed countries. In the chronic phase, the ongoing infections and inflammation can lead to a gradual lung decline. Patients require oxygen therapy and frequent hospitalization. There is a risk of diabetes, osteoporosis, and other comorbidities increase. At the end stage of the disease, lung failure is the leading cause of death in cystic fibrosis, with a median survival without a transplant being 40 years. Post-lung transplant survival is 50% at 10 years.
If we look at the pattern of pathology, there are 4 defined stages to this illness. Firstly, we observe obstruction, followed by infection, leading to inflammation, and ultimately creation of fibrosis. The pathology of cystic fibrosis follows a distinct pattern that reflects the impact of the CFTR dysfunction across the multiple organ systems. The hallmark of cystic fibrosis pathology is the presence of thick, dehydrated mucus that leads to an obstruction, then an infection, and progressive tissue damage. The progressive cycle drives organ damage, particularly in the lungs and pancreas. Early intervention and CFTR modulator therapies aim to interrupt this pattern and slow disease progression.
CF includes 4 systems and organs. This includes the respiratory system, where we see airway obstructions, chronic infection, bronchiectasis. Then we have the pancreas, where we have mucus obstruction. This includes pancreatic insufficiency, and over time, pancreatic tissue is replaced by fibrotic and fatty tissue, contributing to pancreatic atrophy. We have the gastrointestinal tract with meconium ileus, distal intestinal obstruction syndrome, and bile duct obstructions. We also have the liver, where we see biliary cirrhosis. Over time, this can progress to multilobar cirrhosis and with the risk of portal hypertension.
So looking back at the case report, the patient's presentation aligns with classical features of cystic fibrosis, including chronic respiratory symptoms, recurrent infections, and gastrointestinal issues. Compared to standard literature, the case highlights a notable combination of persistent respiratory decline despite optimal treatment, and an unusual presentation of mild gastrointestinal symptoms, which is less commonly emphasized in typical cystic fibrosis profiles. Key features such as a digital clubbing, sputum colonization with Pseudomonas aeruginosa, and a positive sweat chloride test were consistent with established diagnosis criteria. However, what distinguishes this case is the delayed diagnosis despite recurrent symptoms, emphasizing the importance of heightened clinical awareness in atypical cases.
In conclusion, cystic fibrosis is a genetically inherited disease that is caused by a mutation in the CF or TR gene. This case report shows the pathological characteristics of cystic fibrosis, highlighting the vital roles of progressive tissue destruction, persistent infection, and mucus blockage. The patient presents with classic CF pathology, including chronic respiratory symptoms caused by neutrophil-driven inflammation, airway mucus plugging, and eventual bronchiectasis. Furthermore, the systemic aspect of CF pathology was established by pancreatic involvement that resulted in ductal blockage and fibrotic alterations. In order to lessen the continuous loop of blockage, infection, and fibrosis that propels CF disease, this instance emphasizes the necessity of tailored medicine that addresses the underlying CFTR failure, decrease mucus accumulation, and regulate inflammation.